I'd like to welcome you to this NEWS2 update. By looking at this presentation, it's not intended that it will replace any existing training, such as the Vital Signs course or the online e-learning course provided by the Royal College of Physicians on NEWS2. This is supplementary training to help improve our focus on some additional areas. By the end of the training, it's hoped that you'll be able to understand some of the common issues when completing observations, understand some of the issues that we come across when completing particularly NEWS2 and understanding the scores, and also the NEWS2 escalation plan and making sure that we are following that. When we're completing observation, NEWS2 is an effective tool if we understand the context for each patient and we act on the scores by following the NEWS2 escalation plan. The NEWS2 scoring tool can be found under the P button on Meditech, or many ward areas also have a laminated copy attached to the computers on wheels or on the observation machines. NEWS2 was built for its sensitivity to allow early intervention and swift action. So it's important that we look at scores in conjunction with previous scores. They should never be looked at in isolation. We should be looking for trends, and to help with that we should ensure that we have our computer on wheels at the side of the bed so we can actually input the scores and the observations as we take them from the patient. One of the key things that supports improving fluid balance is to ensure that when we complete our observations, we also complete fluid balance at the same time, and these should be opened on the work list together. One of the key areas is understanding the parameters and the scores, and we should also make sure that once we've completed a NEWS2 observation that we go back to the work list on Meditech and change the frequency of obs if it's required. Meditech doesn't do this for you. So this is the NEWS2 scoring tool, which hopefully everybody is familiar with, and we're just going to go very quickly through some of the key areas that we just need to improve our focus. So we're going to look at some of the evidence-based issues. When we look at the literature, there is a lot of information out there explaining about how respiratory rate and conscious level are both two of the first indicators that we have that a patient is deteriorating. Unfortunately, they're also the most subjective and the most poorly measured. Respiratory rate, really important that we measure this accurately, as it can give us key indicators that a patient is unwell and enable us to act very early. We'll discuss conscious level in the next few slides. NEWS2 has developed from the previous NEWS score to include an update on oxygen saturation scales, and we now, instead of having one saturation scales, also have a second scale. It's important to be aware that this is a scoring tool and it's not the patient's saturation range. The medical teams can select a saturation range which is appropriate to the patient, and then the saturation scale be selected accordingly. So scale 1, the majority of patients will be using. Scale 2 should just be those patients who have a proven hypercapnia, and the advice from the Royal College of Physicians who developed NEWS2 is that this should be based on a blood gas from either this admission or a previous admission. An example of this would be a 30-year-old patient with COVID, which is something we see commonly at the moment. Patient has no comorbidities. The correct saturation scale would be scale 1. However, with COVID, as many of us are aware, the target saturation range generally is 92 to 96. One of the things that NEWS2 doesn't measure is any increase in oxygen. Any patient who's on oxygen is at risk of deterioration. So if we see an increase in oxygen, even by a small percentage, we should make sure this is escalated straight away to a clinical decision maker. This should be accompanied by a review of the patient and at least hourly observations to ensure that the patient is now stable. This is increasingly important with patients on 40 and 60% and above. One of the really useful tools when looking at patients' conscious level is the AVPO score. It's one of the areas where we sometimes struggle as clinicians because it can be very subjective. One of the best ways to look at the AVPO score is that anything that is the patient's normal will score a 0. Anything that is abnormal for that patient will score a 3. We can then figure out exactly which box they fit into. So when you actually looking at a patient that's alert, it's not just about the patient's eyes being open. We have an example from another area where a patient came into an emergency department, awake, talking, alert, fully conversant, and during the course of the stay in the hospital, the patient's conscious level deteriorated, and to the point where the patient wasn't able to communicate, wasn't able to follow commands. But in this circumstance, the patient's eyes were open and as such was scored as alert. But in actual fact, should have been scored as a 3 for voice or a P for pain, because in actual fact, they didn't respond to pain responses despite the fact their eyes were open. So it's really important that we understand each level of the scoring tool. If someone is scoring a 3 for new confusion, this is not just about confusion, it's also about disorientation, slowed thought processes, delirium. It could also be a change in the patient's behaviour. They could be suddenly more aggressive, which is completely out of character for that patient. So it's important that we know what that patient's normal is when we're allocating a score. When we look at the NEWS2 escalation policy, it actually gives us really clear guidance on what level of observations we should be doing for a patient. But it is important to remember that this is just a tool and an aid that can help support our judgment. It doesn't replace our judgment. When we talk about a patient with a score of 0, the minimum level of observation should be 12 hourly. However, if the patient is a patient at risk, they really need to be on 4 hourly obs. Patient at risk could be a number of different things, and this list is not exhaustive. But if you think about the patients in your area, you're likely to know the ones that are more at risk than others. For example, in orthopaedics, fractured neck of femurs are a really important patient to keep a close watch on. Fractured ribs, very prone to deterioration. Anybody who's had major surgery, particularly emergency surgery. And in medicine, anybody with severe asthma or those requiring increasing amounts of oxygen should all be on 4 hourly obs as a minimum. It may be that some of these patients, you even decide to put on more frequent obs, and that is absolutely fine. When we talk about a patient scoring a 1 to a 4, we should always have those patients on a minimum of 4 to 6 hourly observations, and the nurse in charge should be aware. It's important to bear in mind that NEWS2 was built to be sensitive so that we can act early. So if a patient scores anywhere a new 1 to a 4, then we should be acting on that. If we decide we possibly need to decrease the level of observation, this needs to be clearly documented in the patient's medical notes and supported by the patient's consultant. When we get to patients who score a 3 in one single parameter, then the nurse in charge needs to be informed. A 3 in one parameter is highly unusual, and it is either a sign that the patient is about to deteriorate, or it might be a sign that we need to just repeat some of the observations and check that we're accurate with our recording. When a patient scores a 3 in one parameter, they should be on a minimum of hourly observations, as again, it is a sign that the patient may deteriorate further. Their own team should come and see them as soon as possible, and we should make sure that those patients have an escalation plan documented. When a patient scores a 5 to a 6, again, we need them on hourly observations, and they should be seen by their own team within 30 minutes. This is our urgent response threshold, and we need to act accordingly. Hospital at night can also come to review these patients. We should consider whether the patient needs a sepsis screening tool. So anybody with a score of 5 or above and signs of an infection need the sepsis screening tool completing, and they should also be on fluid balance monitoring. Think about whether you need critical care outreach, valuable resource that can help support you in the care of these patients. And again, make sure those escalation plans are documented. If the patient is scoring a 7 or a more, then the patient needs to be on half-hourly observations. Consider if you have the ability to keep the patient on continuous observations, or you can set your observations machines to cycle through 5 and 10-minute obs if it's needed. Patient's own team should see the patient in hours, within 10 minutes of the patient scoring a 7. If the junior doctors have seen the patient, there should be a review by a registrar as soon as possible. If you need emergency assistance and there is nobody on the ward, consider whether you need to put a fast bleep out initially, but then if you struggle, a code red can be used under the number 2222. Make sure if you put this call out in hours that you specify which team you require, whether it be the medical team, the surgical team, or a specific bleep number for the registrar looking after that patient. Out of hours, 222 call goes to the medical registrar on call. Hospital at night can also review the patient out of hours, and again, consider whether the patient needs the sepsis screening tool completing, and all these patients should be on hourly fluid balance. Patients scoring a 7 or more must have a review by a consultant within 12 hours. Again, in hours, the critical care outreach team can come and support and assist in making a plan. The medical team may also wish to consider contacting the critical care team on bleep 722. At this stage, escalation must be documented for the patient and ensuring that we have a robust plan in place should the patient continue to deteriorate. If these patients don't improve after 2 hours, then the responsible consultant must be contacted to review the management plan. Just make sure that for all the patients scoring 5 or above, that we're thinking about sepsis. In any patient with a NEWS score of 5 or more, with a known infection or signs and symptoms of an infection, or a patient who is at risk of infection, always think, could this be sepsis, and escalate that care immediately. Make sure that we're completing the sepsis screening tool on Meditech, and this can be completed by either the nurses looking after the patient or the doctors. So key messages to take away: ensure that we're completing accurate observations, as these are vital for detecting deteriorating patients. The observation frequency must be increased on Meditech on the work list if the patient's NEWS2 score increases. Equally, it can be decreased in frequency if the patient is improving. NEWS2 is designed to be sensitive to allow for early detection of deterioration. This only works if we're following the escalation plan. Historically, on critical care, we often have patients admitted where we can see signs of deterioration hours or often days before, because the patient's NEWS2 score has increased slightly on each set of observations, and therefore the clinician's judgment at the time was that no intervention was required. The NEWS2 scoring tool is there to support clinical judgment. Don't wait for higher NEWS2 scores if you're concerned about a patient. Very often our judgment is completely correct, and patients can often look more unwell than their scores, and this may be a sign that their score will increase, but at the time, seek help and advice before that happens. Early intervention means there's a higher chance of recovery. If the NEWS2 policy or escalation policy is not being followed, this must be clearly documented in the patient's notes and agreed by the patient's consultant. Thank you for listening.